We shall now go on to a talk by Dr. Niraj Sahoo, who's again a vitreoretina consultant from LV Prasad, Vijayawada branch. And he is going to tell us something as relevant, newer macular hole indices versus old macular hole indices. On to you, Dr. Niraj.
Thank you, Chitra. First of all, I'd like to thank Dr. Ashra and Dr. Chitra for this opportunity. Dr. Ridhima has already covered some of the aspects of indices, but we're going to discuss some of the evidences that are there, and we're going to decide whether they're worth it or not. First, let us come to the MLD. So the classification based on IBTS into small, medium, and large. But the large macular hole size of 400 microns was based originally from Gass's work before the origin of OCT and surgery. So basing this as a cutoff for large macular hole is it's not correct in the current scenario. Although definitely less than 400 microns, they have very good visual acuity, visual prognosis, but more than 400 microns, where exactly the cutoff lies, it's very unclear. So this question was addressed by the Manchester Large Macular Hole Study, where they have given a cutoff of around 630 microns, and they had a good area under the curve. Several other studies have also shown much higher cutoff values of around 500 microns. So this really brings us to the question, is it time to redefine large macular holes? But nonetheless, MLDs are one of the most consistent and widely accepted factor correlating with visual acuity and analytical success, and we often use it in clinics for predicting visual outcomes. Let us come to the preoperative macular hole indices individually, and let us review some of the evidences. First, the whole form factor, one of the first indices that came. If you look at the evidence, there are multiple studies that have either shown no correlation or good correlation with either with closure or visual acuity, thus telling us that this might not be a good index for prognosis. On the other hand, if you look at the macular hole index, most of the studies actually talk good about it. So we can see the number of studies showing good correlation with either closure or visual acuity, thus telling us that MHI could be a good prognostic indicator that can be used in clinics. Again, DHI or diameter hole index, which is just a ratio of inner hole diameter with the maximum basal diameter. This tells us that multiple studies that have shown either absolutely no correlation or good correlation with visual acuity or closure, thus telling us that again the prognostic factor or evidence might be slightly low. The THI or tractional hole index, again, the papers are all over the place with no closure or good correlations. Again, this is telling us that may not be a good index for clinics. A slightly newer index, macular hole closure index or MHCI, this actually takes into consideration the curve length. This is not the arm length that was used in whole form factor, but this is the temporal and nasal curve length that was used here. And in this paper, they showed that the area under the curve was much, much higher than all of the rest of the macular hole indices. So this is telling us that this could be one index that might be consistent with the prognosis of the macular hole. Several other studies have shown MHCI to have a very good correlation with final visual acuity, but there's a caveat that a few of the studies have taken the arm length instead of curve length and labeled this as MHCI. So again, they should take it with a pinch of salt. The macular hole angle, absolutely no correlation with final visual acuity or closure rate. When we look at the perifoveal cirrhosis, again, the papers are all over the place with papers showing that it is associated with poor closure or poor visual acuity. And again, papers are there which have shown that they're related with higher closure rate and better visual acuity. Now, this is just presence or absence of cyst at the hole margins. But when we quantify it, Dr. Ramesh Venkatesh's paper has quantified it using ImageJ, and they have binarized it and analyzed 3 different indices: macular hole area index, macular hole tissue area index, and macular hole cystoid area index. And they have shown that there could be a possible predictive value. As you can see, the area under curve was quite significant and with a significant p-value. But again, when the other papers are there, which have also quantified the area of cyst, but they all have given variable outcomes with respect to the closure rates or the visual acuity benefit. This paper by Dr. Uni's group had quantified it using actually on-face OCT, and they have shown that the area with higher cyst area were associated with poor postoperative visual acuity. So just to summarize all these indices from only MHI and MCHI, and to some extent the quantification of the cyst, were able to predict the functional and anatomical outcome of macular hole. No presentation will be complete without the presentation on machine learning on AI. This paper nicely showed how they used AI to actually measure the different indices, including the diameters and the angles, and they could, it was as accurate as manual measurement. There are several other deep learning models that have been developed that have been used to prognosticate closure rates. I'll not go into detail, but these are some of the examples that have shown a very nice correlation with the closure rates and visual acuity outcomes. Quickly moving on to the postoperative OCT biomarkers, we already know the types of macular hole closure rates, the U, V, and W type. Q being very nicely associated with good visual outcomes. The type 1, type 2, type 1 closures are very nicely have very nice visual outcomes. But there is a much more recent classification based on the continuity of the retinal layers, either stage 0, 1, or 2. In stage 0, it is open hole. Stage 1, there is some continuation of the retinal fibers, but there is some gap in some bridging of the retinal tissue in some subtypes. But in stage 2, there is some in some subtypes, as you can see in stage 2B, there is some continuity, but most of the rest of the area is filled up by glial tissue. As you can see in their table, they have shown that in cases where they've used amniotic membrane implant or autologous retinal implant, the holes closed mostly with stage 2 type of closure, type 2 type of closure. So there is much more amount of glial tissue than the other types of surgeries. I'd also like to highlight much more recent classification that we have described recently, that is based on face OCT. Either it is a linear or a round or a centripetal closure. As you can see here in the photographs, much more oval orientation of hole at baseline resulted in a linear closure, while a round hole resulted in a round type of closure. So this is how it looked in pre-op and post-operatively. And we found that eyes with linear closure had much better visual acuity than round closure group in eyes more than 650 microns. But this was not true. There was no difference in eyes which had less than 650 microns hole size. Just to like to conclude with a few of the changes that happen that can be picked up post-operatively also using OCT or on-face OCT. The first is the sample or swelling of arcuate nerve fiber layer. It can be picked up either with autofluorescence or infrared reflectance imaging. It can appear as early as 8 to 10 days post-operatively and gradually disappear in 2 to 3 months. They represent swelling of the RNFL, and they have been proposed to be due to surgical trauma from the forceps or due to damage of the Muller cell and plates that result in exoplasmic flow disruption. The downfall initially described by Tadayoni's group in 2001, but it was only described using blue filter photography after ERM removal. It was later on changed, the terminology was changed to CMDS or concentric macular dark spots, because these were not actually dissociation, but they were actually cleavage lines, and they extended beyond the RNFL into the GCL or IPL, as you can see from this OCT and on-face OCT images. They appear between 2 to 6 months, but they do not decrease or resolve even with long-term follow-up. Few other changes include temporal macular thinning, retinal nerve fiber thinning, or GCL complex thinning. These are some of the indices that can be used preoperatively or postoperatively. It's up to us to decide which to use in clinics. Thank you.
Thank you for the wonderful talk. if I have to ask you, like, which is the apart from MLD, if you want to use one, you constantly use one indicator in your day-to-day practice, what would be that?
I usually sometimes use MHI. As I said, the evidence is quite good. And if you look at it on the perspective of a drawbridge, so if you consider a drawbridge which has a big base, and if the height is more, it will tend to oppose with each other much better than those who have a smaller height. So MHI, both in terms of evidence and in terms of if you apply some logic, it gives us better idea whether the hole will close postoperatively or not. So I would like to use MHI.
Ramandeep sir, do you think like all other entities have multimodal imaging? So we in macular hole, it's only OCT based. Do you think 3D structure we are trying to interpret in a 2D structure? Do you think there is a need for composite indices involving all the multimodal imaging, or whatever we have are good enough to predict the visual outcome and functional anatomical outcome?
Yeah, so I think what Dr. Jatinder has already said, I totally believe in that actually. So if I have to really go for indices. My indices remain, the kind of a size of the hole and the how symptomatic the patient is, and the autofluorescence works a lot. So I don't want in a multimodal imaging anything else. Just an OCT and autofluorescence are good enough to tell the patient prognosis, and they work most of the times in these patients actually. Yeah.
So you are saying OCT and autofluorescence will you win the game in a macular hole surgery, both preoperatively and postoperatively?
Absolutely. Yeah.